Hi, Kailey.
Hi, Bill.
Looking good.
Hi, Jen.
Hello, how are you?
Hey, thanks. So nice to have you here.
Oh yeah, I will be all of it here.
So, Jen, we're making progress on that Markov chain and Monte Carlo stuff. So
Okay.
we followed up on what you recommended, and we'll get everything's right. The PI is in Uganda, but he'll be back next week, and then we'll meet with him.
You want me to be part of that, or
Yeah,
you?
I think it'd be very, very helpful if you're willing.
Oh yeah, yeah. So of course. So
All
let's
right.
discuss
Well,
that, and then yeah, if you can hold off the PI, and then we can discuss further to narrow down the framework, the work, so we can get it done faster.
exactly.
Yeah. Okay. I don't want to take your time, so now you just go ahead.
Oh, okay. So
Oh,
are we on
although
our?
I'm not the chair, so
Okay. No, you're not taking time. We're just waiting for
yeah.
people to
So,
join.
yeah, so several people, it looks like several people are joining as we speak. Gary, just let us know when you want us to get started.
Yeah, it's scary. It's scary.
Okay. Gary indicated any time. So, Bill, if you're ready, we can go ahead and kick it off.
I'm ready, Kailey. Thank you. Go for it.
Okay. Thanks everyone for joining us today, and welcome to today's CHS Innovation Talk. So today myself and Dr. Riley will be presenting on barriers to implementing value-based payment and improving population health in the United States. Some brief introductions. I'm Kailey Love. I'm a research project manager in the College of Health Solutions and working on pursuing a doctorate degree in biomedical informatics. And co-presenting with me today is Dr. William Riley. Bill, do you want to introduce yourself?
Kailey, thanks. Hi, good morning, everyone. I'm Bill Riley. I'm faculty in CHS. I am delighted to be here. And Kailey, thank you for asking me to join you in this presentation. And I see a lot of colleagues, so thank you so much for spending your time on this presentation. Kailey, back to you. Hi, Scott.
So in addition to Bill and myself, we had a larger research team in the projects that we're specifically speaking about today, and that included Dr. George Runger, Stephanie Turner from Valleywise Health, and Cameron Adams from the state Medicaid agency, also known as Access. And with that, I'll hand over the next segment of the presentation to Bill.
Kailey, thanks. So the title of this presentation is Barriers to Implementing Value-Based Payment and Improving Population Health in the United States. So why don't we start with population health? What's the goal of the healthcare delivery system in this country? So what's the purpose and the function? We'll make this interactive, but we can't. If not, then I'll just ask rhetorical questions. Scott, I see you smiling. You want to jump in, or should I continue?
So
Okay.
go keep going.
Okay. All right. So we could, within a short time, we'd probably all agree. We'd start with different ideas, but we'd come up, well, the function of the healthcare delivery system is to improve the health of the population. So let's start with that. And if that's the goal of the healthcare delivery system, most of you know we're not doing a very good job at that. So this study was released by the Milbank Foundation just last week in the Milbank Memorial Quarterly. And if you look on the, Kailey, if you could use your mouse, please. Yeah. There are 5 dimensions on the left side, and that's basically the triple aim plus 2. So access, care processes are the quality of care that's delivered. Administrative efficiency is the bureaucracy. Equity, we all know and how important that is. There's no quality without equity. And then the outcomes are the quality of care that's delivered. So those are the 5 dimensions. And if we look at the major industrialized nations of the world, We also know, for example, that that we dedicate a lot of our society resources to healthcare. Almost 20% of the GDP in our country is for healthcare. It's just about $5 trillion now. The physicians in this country are the best trained people on the planet. The other clinicians are committed and hardworking. All of our clinicians are hardworking. So it stands to reason that we're number one in rankings for population health. Well, we're not. You can see in the far right-hand corner, right-hand column, that we're last among all these countries. And this is similar to all the studies that look at population health rankings. The OECD also issues a study every year, and we're 30 out of 30th. So that leads to the question is, next slide, please. Why does the United States healthcare system perform so poorly? It's not because we don't have tremendously hardworking people. We have excellent trained people. What is it? Well, every system is perfectly designed to produce the results it's producing. And so our system is designed for sub-optimization. And what sub-optimization means, so we all have, the healthcare industry, again, is 20% of the economy, but it has all sorts of subsections and subsectors: the hospital sector, the insurance sector, the medical device sector, the safety net sector, and so forth. So that goes on and on. But all of those sectors are designed for sub-optimization. And what that means is that every sector is doing its best to do its part. And depending on where the sector that delivers the value and creates the value is located. Yes.
Did I miss something? Okay, good.
Oh, that's not for me, is that correct?
I think that was a mistaken.
Okay, right, got it, thank you. Okay, so our healthcare system is stuck in a rut. And next slide, please. So all of you have touched on in your areas, I think, based on all my discussions with you, that there's structural reasons why our healthcare system is functioning so poorly. There's especially in geographic maldistribution. A study was just released yesterday, again by, I think it was in the Milbank Quarterly, that our primary care physicians are about half, ratio is about half of what Canada is. So we have a terrible geographic and specialty maldistribution. In our country, about 75% of the physicians are subspecialists, and about 25% are primary care specialists. In all of the other countries that were on the previous slide, the ratios are exactly the opposite. They're about 75% primary care and about 25% specialists. The entire healthcare delivery system is fragmented and broken and siloed, and that's that is basically what we are going to show today. The administrative bureaucracy is totally out of control. They're at the top of the pipeline and dribble everything out to everyone else, and makes it very, very difficult for the clinicians, the nurses, the therapists, the physicians, and so forth to provide value and to care for the patients. And the reason that we need to emphasize that is because most of the value in the healthcare delivery system is done at the microsystem level. It's between the interaction of the physician and the patient, the provider and the patient, the therapist and the patient, the clinician and the patient. It's not done by the health plans. It's not done by the policymakers and so forth. It's done it's not done by the hospitals. It's done by the caregiver at the direct interaction. And that is where we waste the most talented resources we have. Another reason, defensive medicine. Patients do have an important role in terms of compliance behavior and health behavior and so forth. The moral hazard of insurance, I know some of you are experts at. And then the payment system. So let's talk about the payment system. Next slide, please. There are basically two ways to finance healthcare in this country. One is the fee-for-service system, and the other is value-based payment. And fee-for-service pays for volume, and it's retrospective. In other words, the clinicians, the physicians treat the patient and then they bill the payer. That's why it's called retrospective. The fee-for-service system, we're getting exactly what we want. It's a runaway nuclear reactor. About 30% at least of the care that's delivered in this country is considered, it's not a bad word, it's a technical word, it's considered waste. In other words, it doesn't affect the outcome. And the three main failures in terms of care delivery are overuse, underuse, and misuse. So those are all value deleters. Now, what value-based payment system, that's the other type of financing, pays for value. In other words, it pays for those dimensions that you saw on the earlier slide. It pays for creating access. It pays for having process efficiency. It pays for outcomes. And that's what's called prospective payment. In other words, the physicians know in advance what the payment is going to be. And there are a number of different ways to do that. But it's really important to keep in mind the difference between fee-for-service and value-based. Next slide, please. And this is CMMI, the Center for Medicare and Medicaid Innovation, created the Learning Action Network as part of the Affordable Care Act. And their original goal 10 years ago was to convert all of healthcare payments from fee-for-service to value-based payment. And the first column is fee-for-service care, which has no link to quality or value. And then the other three columns are different forms of value-based payment. I won't get into that, but there are at least 30 ways to design and implement value-based payment. And that's what we do at the Safety Net Advancement Center, the National Safety Net Advancement Center in the College of Health Solutions. Is about a third of the country is treated, the patients are treated by safety net organizations like federally qualified health centers, the public teaching hospitals, rural hospitals, community mental health centers, and so forth. So over 100 million people are served by that, but they don't have the ability or the resources to respond to value-based payment. And that's where we focus, is how do we assist the safety net sector in our nation to respond successfully to value-based payment and structuring their organizations to achieve value. Next slide, please. All right, and then the Learning Action Network that I started to explain on the other slide, the goal for this Learning Action Network, and it's a consortium sponsored by Medicare and Medicaid that consists of both private insurers and the public payers. And they've had a series of targets that keep moving. So they've been kicking the can down the road for the last 10 years. But the most recent aim is that this year, 25% of all Medicaid, 25% of all commercial care, and then 55% of Medicare Advantage and 50% of Medicare will be on a value-based payment structure. And then by 2030, it's 100% for Medicare, and then 50% for Medicaid and 50% for commercial. So if our goal of the healthcare delivery system is to improve population health, the current financing system has not gotten us there, and it will not be able to get us there. Next slide, please. And that's why value-based payment is so important. So the focus that has been discussed so far is what are the structural problems in the healthcare delivery system that we are not able to provide the care so that we have the outcomes that the physicians want to deliver, that society wants to have. So there are a number of structural barriers that the physicians are handcuffed and hamstrung. And all of the healthcare deliverers at that microsystem level that create most of the value, they're in a hamster wheel. And we need to reverse that structure completely. So next slide, please. I think actually, if you could go back to the previous slide just for a second, Kailey. So how do we successfully implement value-based payment? So how to do it? Well, as I started to say, all of the value, most of the value is created at the microsystem level. So how do we focus the resources and how do we create the settings and the conditions so that our clinicians can treat patients the way they need to be treated? What to do? Well, that means it needs to be patient-centered and physician-driven healthcare rather than outside-driven healthcare and health plan-driven healthcare and so forth. And then what not to do? Well, don't make it outside in, top down. Next slide. All right, so all of that was a lead into what is really the focus of this presentation. And if Kailey would have told you that the focus of this presentation today is going to be on patient and patient attribution, you would yawn and not come. We thought through, how do we explain the complexity of this issue? And how do we explain to you why it's important and how it is so important and how it is one of the major contributors to successfully implementing value-based payment? So if I tweaked your interest enough yet, thank you, Scott, because this is very difficult to explain, and it'll probably be challenging to understand. But please stay with us and keep the focus on what's the structural issue here and why is this important and why does it need to be done right? Okay, so patient assignment. Patient assignment is fundamental to being able to care for populations of people, to improve population health, and to have it done at the microsystem level. That's what patient assignment is all about. Next slide, please. And if we jumped right into patient assignment, we know for sure that that it would turn all of you off. So we thought through, how can we do a thought experiment to show exactly what empanelment is all about in healthcare? So some of you are, all of us teach courses, and think about if we were structured this way. Now remember, every system is perfectly designed. So suppose our ASU course system was designed in the following way. So for those of us who are teaching Spring B, and we have a course in spring, it starts in a couple weeks. The first day of class, so the first day, 60 students show up for class. We're all good? Okay, we've all been through that. And as an instructor, you're given a list of 60 students. So 60 students are in your class, you know who they are, you walk into the class, and 60 students are there. So we're all good. And you go down your list, and you find that 30 of those students are on your list. So 60 showed up, you're expecting 60, you take roll call, and only 30 of the 60 students are in class. Okay? They were assigned and then they show up. That's called a true positive. All right, next. But the other 30 students have shown up in your class, but they're not on your list. Those are called false positives. Okay, so they say, well, yeah, we're here, but you're not my instructor. I'm in Dr. Merkel's class, or I'm in Dr. Naidu's class. But I think I'm just going to stay here. And then, so 30 are on your list. 30 of the students are not on your list, but there are also 30 other students who are on your list, but they're going to somebody else's class. They're going to Scott's class or Din's class. Those are called false negatives. Now, when you show up for class and you're told that you have 60 students, you expect to spend the next semester with those 60 students and do the best you can to help them learn your specialty area and to prepare them for career success. Okay? And then just one other thing, we don't do this in academics, but this is the way healthcare is financed. one other just small little thing, 25% of your salary depends on how those originally 60 assigned students perform on standardized tests. So for a faculty who's compensated $100,000, you're only going to get paid $75,000. And if your students perform on the tests, you'll get the additional 25,000. If you don't, then you don't get paid. You just get the 75,000. So anybody have any questions or comments on this thought experiment? How many of us would like to perform our scholarly academic work under those conditions? Okay, rhetorical question. All right, enter patient assignment. Now we're going to show an example of exactly how value-based payment is designed and structured in this country. Please keep this in mind. It gets very confusing when Kailey starts describing true positives and false negatives, but it's exactly the same thing as what this thought experiment is here. And so it may not make sense the first time, but we're going to go through it 2 or 3 times and show different examples. And then by the end, it will make sense in terms of how this system is perfectly designed to not be able to treat patients properly and to achieve quality outcomes. So with that, I think, Kailey?
Thanks, Bill. So as Bill indicated in setting the context and setting up kind of the thrust and background of this study, there are 2 key methodologies that value-based payment relies upon: patient attribution and patient assignment. Patient assignment, and they tend to be used interchangeably, so it's important to distinguish between the 2. Patient assignment and attribution systems are designed by payers to identify the physician-patient relationship, to designate physician accountability for the cost and quality of care as a mechanism in value-based payment methodologies. Patient assignment is done by payers to prospectively assign patients to physicians during a performance period. This assists the physicians in identifying their patient population and facilitating proactive population health management efforts. And so this assignment list is often done by one of 2 ways, the first of which being the patient selects their physician themselves, or the second, which is more often than not what happens, the payer automatically assigns the patient to the physician using a proprietary algorithm that is typically based on geography and panel availability. And then attribution is involved and led by the payers as well. This is almost always done retrospectively and based on claims, and this establishes the accountability for a physician and oftentimes involves unassigning that original assignment. So prospective patient assignment is designed to create a physician-patient relationship for population health management, whereas attribution assesses the extent to which physician-patient relationships actually occurred. So in the study that we're talking about today, we'll investigate the congruence between health plan patient assignment and established patients at a local healthcare system. We'll examine the association of patient assignment with quality performance, and we'll discuss the implications of patient assignment incongruence upon patient care management efforts, quality performance, and its relationship to patient attribution. To better understand this distinction between assigned and established patients, we define established patient as an access-enrolled individual who received at least 2 primary care visits during the study period at the study setting. An assigned patient is defined as a patient prospectively assigned by a health plan to the study setting using assignment files from 5 different health plans. So assignment files are transmitted by health plans typically on a monthly basis, and have an ongoing list of the patients that are assigned to that care setting. So study design, this is a retrospective cross-sectional study that analyzed data from January 2020 to February of 2022. Study setting was Valleywise Health, a local large healthcare system. And the study population included all Medicaid enrolled patients who received primary care services from Valleywise Health and/or were prospectively assigned to a Valleywise primary care provider or advanced practice provider from 5 healthcare plans here locally. Bill, you want to take back over?
Kailey, thanks. So again, Kailey is going to go through this in a number of slides. We're going to show the actual structural features of this assignment, but let's please think back to that case study thought experiment just a few minutes ago, that if you have 60 patients that are on your class roster, that's called empanelment in healthcare. So it's patient empanelment. So the physician is told you have 60 patients, just like you are told you have 60 students enrolled in your course. So when you expect throughout that course that those 60 students, unless they drop or whatever, you're going to start with 60 and end up with 60, and you're going to work together. Well, that's not the way empanelment works in healthcare. So as Kailey indicated, Kailey, why don't we start with the first column, the established patient and non-established patient. So the established patient, just consider that's your student. That's your student who showed up for class. The not established patient is a student who's on your roster, but they never came to class. Okay, so now let's look at the assignment, the top row. Okay, the assigned patient is the patient who your roster says belongs to you, and the not assigned patient is the patient. Sorry, I said patient. Yeah, patient is that student who they're not on your roster. They're not assigned to you. They're assigned to Dr. Siegler, they're assigned to Deb Williams and so forth. They're assigned to Chad. So they're not your student, and they're somebody else's student, and end of story. Let's go through what the four alternatives are then. So for the established patient who's assigned to the physician, that's a true positive. In other words, the patient knows that Dr. Smith is their patient, and Dr. Smith knows that Mr. Jones is her patient. That's called a true positive. All right, but there's also patients that the health plan impanels and says, Dr. Smith, Mrs. Stewart is your patient. And Mrs. Stewart says, no, I'm not Dr. Smith's patient. I go to Dr. Stetcher. That's called a false positive. And then on the non-assigned patients, all the other patients that are assigned to some other physician, or all the other students that are assigned to another faculty. So the middle cell there, the false negatives, Kailey. So the false negative is a patient who is on who's not on your list of 60 students, but in fact, they're on Dr. Merkel's list, but that student decides to come to your class because they like you. And then the true negative is a student who was not in your class and did not come to your class. So stick with us on this. We'll keep going through it so that it gets less confusing. Back to you, Kailey.
Okay, so taking that framework and applying it to this study, the table here summarizes the number of patients based on these classification categories, using those definitions of established and assigned and placing them into the four categories of true positive, false positive, and true negative. So in the 2-year project period, there were 100,030 Medicaid patients seen at Valleywise and assigned to Valleywise. Of those 100,030 patients, 74,000 were assigned to Valleywise. However, of the 74,000 who were assigned, only 15,000 were actually seen at Valleywise Health, meaning that only 15% of the population were considered true positives, those that were assigned and established. Conversely, of the 100,030 patients, 41,000 were established at Valleywise, and of those 41,000, only 37% were actually assigned. So taking this a little bit further, this table here summarizes the number of patients and their respective classification categories across the 5 health plans, denoted by A through E in the first column here. As you can see on the previous slide, 15% are true positive, 26% are false negative, and 59% are false positive. Of the true positive patients, those that were assigned and established at Valleywise, there's a wide range in performance ranging anywhere from 6% to 22%. We then took this a little further and looked at specifically those false positive patients, so patients assigned but not established at Valleywise, to see where they were going. And as you can see here, 2.7% of those false positives had at least one visit, since our definition for an established patient was 2 visits during the study period. 36.7% did not engage in any PCP services whatsoever, and 60.6% had at least one visit with a PCP outside of the Valleywise Health System. We also took a look at quality performance based on these assignment classifications using 4 HEDIS quality metrics. So we took a look at diabetes screening and 3 well-child visits for ages 0 to 15, ages 3 to 6, and adolescent well care. And so as you can see here, the figure indicates that the performance for established patients, so true positives and false negatives, were significantly higher in comparison to patients who are not established, so false positives. And the next slide, I'll hand over to Bill to talk about discussion.
Great. So again, we're going to go through this again to describe what you just saw and then start describing what the implications of that are. So think of it in terms of students and it'll make total sense. So of the 100,000 students in the lower right-hand corner, Kailey, if you could, yeah, okay. So a total of 100,000 students, and of those, now let's go up to the true positives. For all of our faculty, that for the 100,000 students, 15,000 of those were actually on your class roster when you started the course, and they actually showed up and they said, this instructor is my instructor. So in other words, 15% are correctly impaneled, 15%. 15,000 out of 100,000. So now remember, 25% of your compensation is based on how these patients get treated. So patients, what this indicates is that the patient assignment methods to physicians are extremely unreliable. And the true positive classification, in other words, they were assigned and they considered the Dr. Smith, their patient, their physician. It should be a congruent relationship where all of the physician's patients are established and assigned. In other words, that physician's patients should be 100% true positive, but you can see that collectively it's only 15%. An empanelment needs to be congruent so that the physician can be held accountable for care under value-based payment. So to the extent that the whole healthcare system is moving toward value-based payment, and we're halfway there already, and to the extent that all of value-based payment depends on accurate patient assignment for primary care, it is a huge structural failure. And it raises really important concerns regarding patient assignment methods to effectively identify patients for outreach, for engagement, and for population health management efforts to provide ongoing care to the patient. Kailey?
Okay, so Bill just walked us through false positives. This slide looks a little bit further at false negatives, which false negatives are those patients that are established but not assigned. So essentially ascribing patient care management to another physician rather than the established physician that's actually currently providing care. And so as you can see here, 26% of the patients are established but not assigned, but assigned to another physician. And so this indicates that assignment methods may not be sufficiently sensitive to actually identify the physician who is actually treating the patient. Bill?
Thank you. All right, then the false positives. A false positive classification is a patient who's assigned, sorry, to the physician, but is not but doesn't go to the physician. In other words, the patient is on your class list, but decides to go to somebody else's class. This is probably the most problematic category. And the reason is because you can see that about 60% of the patients are false positives. So patient assignment methods, they're designed to assist the physician in conducting proactive population health management efforts. So if 60% are false positives, the physician can't create a physician-patient relationship. It causes confusion, duplication of efforts, and waste to both the physician that the patient is assigned to. It causes confusion to the patient, and it causes confusion to the physician that the patient is actually going to. So it's a system structured for failure and for chaos. Kailey, back to you.
Okay, and then revisiting this quality metric image, and as discussed previously, this figure shows quality performance based on assignment classification for those 4 HEDIS quality metrics, and indicates that patient outcomes are significantly higher for those patients that are established, so the true positives and false negatives, in comparison to the assigned patients who are not established, the false positives, that most problematic category that Bill was just discussing. Bill, you want to hit off
Okay.
the
So
conclusion?
Kailey, we'll wrap this up now. So here are the conclusions. You just saw the data. And by the way, we've also done similar studies for statewide studies, and the findings are similar on all the studies we've done on this. So what the conclusions are is that the vast majority of assigned patients are not treated by the assigned physicians. Only 15% are true positives. The analogy is try to teach your courses and get your students to mastery if only 15% of them are on your list actually come to your class. But $25,000 of your pay depends on how they perform on standardized tests. So what that means is that only 15% of the patients are congruently aligned as an established and an assigned patient. So the best predictor of patient outcomes is to be an established patient. You saw that Kailey showed that the quality is higher on patients who have an established relationship with their physician, regardless of whether it's assigned to them or not. It's about 10 to 15% higher. So this misalignment creates tremendous confusion to physicians and patient, and it compromises care management activities, and it is not effective. The whole point from the health plans is assign patients to a physician so that they get engaged, so that the physicians can activate unengaged patients, and it does not work. It basically ends up with a system where the physicians don't know who their patients are, and the patients don't know who their physicians are. And that is why we're number 11 out of 11. Sorry, that's one of the reasons why we do so poorly on international comparisons. Kailey?
Bill, you think you're going to take the first half of this?
Oh, okay. Okay, so again, I'll reiterate that the patient assignment is staggeringly inaccurate. And yet the entire basis for value-based payment is that a primary care physician is assigned to a patient, and a patient is assigned to a primary care physician, and they get along happily ever after. And what these data show is that's absolutely not correct. Patient assignment is a very, very important design component in value-based payment models, and yet it is not working. And health plans are very resistant to improving that mechanism. Kailey?
Yeah, so in conclusion, a more accurate patient assignment system needs to be developed to strengthen the accuracy of patient panels and assist providers in those proactive population health management efforts. Otherwise, value-based payment systems will not be successful in improving population health, especially if the physician doesn't know who their patient is and the patient doesn't know who their physician is. It's a problematic system. And with that, we're to the end of today's presentation. Any questions?
Feel free to either chat or just, yeah, raise your hand. Go ahead, Scott.
So a really nice presentation. As you said, it's certainly very complex. I guess a couple of questions I have. One is as a I can relate to some of this as a and now that I'm on Medicare, as a retiree, and you see these plans that are Medicare Advantage. You referred early on to the Medicare Advantage versus other plans, and Medicare Advantage. My sense is oriented toward the idea of getting a person into the system, to work with a regular provider and work within the system that you choose. So I'm wondering if that's number one, if that's accurate, that's kind of, if that's an attempt to achieve what you're talking about, and is that working? I mean, is that, and not that it's working, or is that a better system than the non-Medicare Advantage kind of system in a because that's a capitated system, right? The Medicare Advantage basically is capitated. So anyway, I'm just curious your thoughts on that.
Those are really good questions. Yes, Medicare Advantage is capitated, but the bulk of it, the capitation goes to the health plan, not to the provider group. The two best examples of what you're just describing are Kaiser and the Veterans Administration. They do it very, very well.
Yeah.
Um, the you put your finger on a really important point, which is in the late 1900s, like 1980s to almost 2000. That's the way value-based payments were structured in this country. It was called capitation. And for lots of reasons, because it was gamed and there were I won't get into the reasons why that didn't work, but as a result of that, the next generation of healthcare financing was freedom of choice. Nobody's going to tell you what physician to go to. You do whatever you want, and we'll pay for it. And that perspective underlies patient assignment and patient attribution that the health plans are still doing 24 years later. And it doesn't work. It's not working. And there are ways that can be fixed. When I was a health plan CEO, and then later I was a CEO at a Blue Cross plan, we had mechanisms that provide alternatives, but they're not the way that the health plans are doing it now. Did that answer the question?
Kaiser, a friend of mine is in Kaiser system and loves it. And if I guess one other quick question, I don't want to interrupt if others want to ask as well, but the other question I have is, as you're talking, it struck me that, or it occurred to me that obviously we're talking about a very complex system, with a variety of factors that are that are trackable or in a straightforward way, maybe some that aren't. But it all seems to me that it lends itself to analytic approaches like agent-based modeling, to better understand that complexity. I mean, this is kind of, I would characterize what you're talking about as a wicked problem. I don't know if you know that term or not, but I mean, because it's so complex, it's so difficult to not to get one's arms around, but also difficult to find the right place to intervene to make it a more effective system. And that, so, one could potentially do kind of modeling approaches, it seems to me, to begin, to sort of, in theory, at least test out different approaches. But, are you folks doing that, or do you have others that are doing that? I mean, I think there's a group in WashU that's doing some of that kind of work, but I don't know if others at ASU are.
Yeah, Kailey, do you want to tackle that?
Do you want to kick it off, Bill? And then we also have some questions in the chat, and then I think
Sorry.
Dan might have a
And
question.
Danny's here too. Yes, we're working with all 7 health plans, and Access has finally appreciated the importance of this, because in one of our projects with Access, the single biggest failure mode for, they have 2.2 million patients' lives in Access, is as we are working with process failures and cause and effect and so forth, was the failure of the assignment system. And so finally, Access has realizes that the health plans need to figure out a way to have one system. Because currently so imagine the complexity of the system that was just explained to you. And Kailey went through a slide that showed that each of the health plans is performing differently on the accuracy of the patient assignment. And the reason that's contributes to the chaos is each of the 7 health plans do it differently. So the physicians have to deal with 7 different assignment systems. And so, yes, so there's lots of opportunity there to standardize and to work together. And that's one of the next projects we'll probably be embarking on.
An additional comment to that is, prior to this work done in this space, there really wasn't much analysis done in patient assignment and accuracy and the impact upon providers. And subsequently, as a result, Access has implemented policy where now there's a quarterly review process for patient assignment files. Because prior to that, we're getting 15% true positives as we're defining it. And so over the next couple of years, we're hoping to see a lot of improvement in here that moves that ball further along. But before, any follow-up questions, Dr. Leishao?
Yeah, actually, sorry, Scott. How about Danny, then we'll go to the chat room. But Scott, to answer your question, the BMI has tremendous students, and they also have one outstanding doctoral student who's doing a dissertation on patient assignment. So yes, so CHS is working on this. Danny?
Yeah, this is actually less of a question, and part of it's a comment and something I'll pose for this discussion. And part of it is also addressing your question, Scott. Medicare Advantage has been growing by leaps and bounds. It's almost 50% of the Medicare population at this point, up in the 40s. But I'd like to stress that the vast majority of that is not managed care like Kaiser. They are paid capitated to the payers, but actually they have independent contracts. I've worked many years with United Healthcare's data, who has an enormous Medicare Advantage thing, and there's nothing about it is capitated other than a payment that United Healthcare receives. The rest of it, there are benefits, there's co-pays. It's a different cost-sharing scheme than you would have under fee-for-service, but it's definitely a bit of a hybrid. And part of why that growth occurs, and here's the scary part, we'll say, great, why don't we all make it Medicare Advantage? I've got a paper that'll be coming out in IMSOM soon, which is one of the top industrial engineering journals, that highlights very clearly stuff that folks in the field already know, that Medicare Advantage plans actively work to get sick people off their rolls. And the reason why Medicare Advantage can work as well as it does is because the sickest people are on traditional Medicare. And they work very hard to subsidize benefits and structure the reimbursements to make sure the sickest patients leave Medicare Advantage plans. So it's not a silver bullet. That's the only thing I mean in terms of capitation for solving that.
Yeah, Danny, it's called cherry picking.
Exactly. And there's strong evidence for this, and that's what's led to the growth and leading people to move to these highly profitable plans, partly because reimbursements for Medicare Advantage are partly based on the overall expected cost of a Medicare patient, including traditional Medicare, so they could arbitrage the difference in cost. The other thing I'll push back on this, this patient assignment problem is definitely a strong issue that isn't going to lead to improved health outcomes. So I'm completely, from everything I've done, completely on board. I'm unsurprised by the results. This is exactly what I would expect to see. And it's great to see these results and hopefully come out in print and publication. But I think the key thing is that other than the PR people and the quality officer who's a true believer and thinks that we set up quality programs for quality, right? And this sounds a little cynical from my career, but I don't think anyone seriously believes these programs are set up to improve quality. And that's by design. Great. It's from the payers trying to figure out how can we hold hospitals and physicians more accountable to cost, even for cost they don't even control.
Right.
So think about, control. You're responsible for patients who aren't assigned to you. You're responsible in bundled payments for leakage that falls outside the fixed bundles, things like joint replacements and stuff. Or even the accountable care organization framework, which is a quasi-managed care, which basically says your healthcare organization is now assigned this patient and you're responsible for the cost, even though you can only control 30, 40, 80% of it, depending on the context. It's really risk sharing and cost adjustment sold, it's a wolves in sheep's clothing. It's sold as quality. It's sold as a way to improve quality. No one built these systems to actually change quality. They're trying to lower cost. And that comes at the expense of quality, unsurprisingly.
Yeah, great. Thanks, Danny. Kailey, there's a chat.
Yeah, so we have a unanswered chat question from Rachel Levine on why not allow a patient who is assigned to ValleyWise choose who their physician is. And so I can jump in on this one, at least to answer initially. So patient assignment is done by the health plans. And I believe across the health board, the one thing that all the health plans have in common is that patient choice is the first step. The patient can select who their physician is. Part of the problem with that first step is it's not very well known how to do that, especially from the patient perspective, that they can do that and where to do that. And even if they can, they don't usually follow up on doing it. So patient choice is the first automatic step. And clearly there needs to be more work done there because perhaps that would help with consistency. Bill, any additional comments on that?
Oh, you
question?
nailed it, Kailey.
Okay.
So that is step one. That's the most important feature, but it's also the biggest problem. So an effective solution needs to balance freedom of choice with accurately creating a relationship.
Right. And I think to expand on that further, in lieu of the patient not choosing, which does happen more often than not, then the health plan will auto assign. And as we found out in the early days of this study, is auto assignment is often just based on geography, and the nearest provider that has open panel availability can take in new patients. And so going through the policy change that I referenced from Access, where they're doing a quarterly analysis, we're hoping that the methodologies used by health plans will improve and become more accurate and more sensitive to care patterns.
I have another question.
Sure.
So it wasn't covered in the presentation today, so I just for accuracy for me and making sure I'm informed and know, but someone had explained value-based care to me also as like you have a patient and then the provider assesses that patient and their current wellness, if you will, and potential for further medical needs over the period of a year. And then like a value or a number is associated with that patient that gets submitted to insurance. So let's say it's me and I am estimated to cost $100,000 for the year to cover for my medical care. If I stay healthy over the year and let's say I only tap into $50,000, the provider gets to keep the other half of the 50K. Whereas let's say I go beyond 100,000, then the provider has to manage that cost. They keep that cost. Is that accurate?
Yes, it's accurate, but there are no arrangements that I'm aware of in the nation today where the physicians are capitated directly. Like Kaiser is a capitated system, but the physicians are not capitated.
I'm sorry, I don't know what that word is. Capitated?
Well, what you just described, where either you're 50,000 under or 50,000 over, that's called capitation.
Okay.
And that's one thing not to do, is to never ever put physicians or other providers at risk Right, because that's an insurance function. It's the insurance company's responsibility to assess actuarial risk along the lines that you just mentioned. It's the physician's responsibility to provide high quality care and to manage the patient's care. Did that answer the question?
Yeah. So it sounds like that's how it works, but there's not really anybody who's doing that right now.
Well, you might remember one of those slides showed that the Center for Medicare and Medicaid Innovation has 35 different value-based approaches. So capitation is just one approach.
Oh, okay.
And the example you just gave is the purest form of value-based payment. The organizations I led, I know that part very well because for 20 years, all of our patients were 100% capitated. And we have the data that shows that the costs are better, the access is better. I'm sorry, the quality is better and the costs are lower. So it can't, without cherry picking, Scott, which was one of the weaknesses of capitation.
So I have another quick question. On one of the slides you showed were like, I think if I understood correctly, were people assigned to ValueWise, but they did not engage with ValueWise, they went somewhere else. Is there any ideas to why they're going elsewhere and they're not engaging with ValueWise?
So
And this,
that's kind of the problem of this disconnect with the mismatching of assignment files and the misinformation. You know, the doctors say I'm Dr. Smith at ValueWise Health. I'm trying to hunt down my patient only to find out they're going somewhere else. And so this is kind of the aspect that Bill alluded to, causing and creating confusion and chaos in the system. As far as specific reasons, it could be, you know, they were already engaged long-term there, but the assignment file that they received wasn't that sensitive enough to pick up that relationship. But our plan is to do future follow-up to kind of do a more in-depth analysis of those patients. You know, where are they going? Why are they going there? Is it truly the misinformation? Is there more going on? I think the biggest emphasis here with this study is just the underlying mechanisms of value-based payment are not well understood and not really well set up structurally to support the goals here. So we're almost at time. Any additional follow-up questions before we talk about, it looks like, upcoming talks here? Okay.
All right. Everyone, thank you very much. We appreciate the opportunity to speak with you about this very important topic, but it's very esoteric. Yeah. Bye. Good to see you, Scott.